Hi guys, this is Dr. Buhler, and we're going to look at a few different dosings of oral contraceptives that can alter the physiological effects on menstruation, on mood, and on migraine. So let's go back and take a look at this very simple diagram of estrogen and progesterone levels that are occurring during a natural menstrual period. Remember that day 0 is the first day of the menstrual period, and about day 14 would be ovulation with a drop of progesterone at the end of the month, which would then come back and cause menstruation to occur. Very basically, we see that in the first half of the cycle, estrogen outweighs progesterone. This causes the growth and buildup of the endometrial lining during that first half. Estrogen then peaks around ovulation and decreases through the latter half of the cycle, while declining very rapidly and very low at the end. Progestin, on the other hand, is low during the first half, but begins to increase to a high level in the second half of the cycle. That's good because while the estrogen was building the endometrium, now progesterone is maintaining it. If fertilization doesn't occur, progesterone levels drop rapidly as well. And it's that drop in progesterone levels that causes the endometrial lining to start to disengage from the uterine wall, which after a couple of days comes back and starts the menstrual period. So it's the drop in progesterone that's going to cause the menstrual period to begin, but it's the drop in estrogen that can actually cause some neurological changes, such as inducing migraines or inducing depression, which we call premenstrual dysphoric disorder or PDD. So when we take a hormonal contraceptive, we're either trying to mimic this cycle or we're trying to alter that timing. So let's take a look at how we can alter that timing. So if we have a progestin-only form of birth control, that's like the mini pill or an implant, and we're drawing the levels here, we're going to have basically the same level of progestin in the blood through the whole month. And because we have no breaks from progestin-only methods, we're not going to have any kind of drop there, and we're not going to have a placebo. The progestin only is creating biofeedback up to the hypothalamic pituitary axis and is decreasing the amount of estrogen. So estrogen's going to stay low this whole time as well. Because the estrogen is low, you're going to have very little buildup of the endometrium. And because you have no drop in progestin, then there's not going to be a menstrual period and there's going to be no fluctuations of these hormones. So with a combo contraceptive, the timing of the estrogen and progestin can be controlled. The original 21-7 pills had 21 hormonal or active pills and 7 placebo. And they originally tried to do this to replicate a natural cycle by increasing progestins through the month. So they may have 7 days of low dose progestin followed by 7 days of a higher dose followed by 7 days of a higher dose, and then the drop off at day 21, which would cause the shedding of the endometrial lining and then trigger the menstrual period. These pills just had 1 dose of estrogen that would be level throughout the month until they also dropped off at the 21 days. So this is fine, and it kind of mimicked the progestin levels in the natural cycle, but it turned out it wasn't really necessary to do that. So a lot of the combo pills that you're going to see have only 1 progestin concentration, and the progestin concentration is going to be the same throughout the entire 3 weeks of active pills and then drop off when the placebo pills begin. So this all looks fine, and it is fine. You have some estrogen that's building endometrial lining, and you have progestin that is maintaining it. When they both drop off, the drop in progestin is what's going to initiate endometrial shedding, while the drop in estrogen is what may cause migraines, PMDD. So for women who have difficulties premenstrually, that's this period of time. And the idea was if you can shorten that period of time, then the estrogen levels may not drop as far, and the period of time that estrogen is low would be shorter. So then people started playing with the number of on days or active pills versus the number of off days or placebo. So you can have pills now in which you have, for example, 24 active pills and 4 days inactive. You add up to 28 still, but you have fewer inactive. So what that's going to look like now is your progestin going along just like it did up here in the progestin only, or here in the level progestin. But it's going to go along not to day 21, but in this example to day 24. If you start a placebo here, now it drops off. In this case, you've got your estrogen levels going along. You're still building some endometrium, but your estrogen levels are fairly steady. Then you come all the way to day 24 before you get a drop off of estrogen. So your estrogen free days are going to be much shorter, and they may not drop off as far to begin with. So basically what you're doing is you are taking the normal number of days that we would consider premenstrual, and you're just shortening them. So instead of 7 days with that drop off, you only have 4 days. There's also pills that give you only 2 days without estrogen. So you can even take this further and have combo oral contraceptives that completely avoid a placebo time. And you take the active pills every single day for 3 months or more. So it isn't just the type of progestin and the dose of progestin and estrogen that's going to matter. It's also the number of active versus inactive pills. And that's really all just based on the kinetics of the drop-off and length of time of drop-off and the physiology that is impacted by the change in progestin or estrogen levels. So I hope that helps explain it a little better than my interpretive dance in class when we didn't have the projector going.